Hello, and welcome to our first part of the gastrointestinal system presentation. So we are going to start with the, as usual, yeah, knowing the X-rays which you can use or a radiological study you can use in the gastrointestinal system. We have, in this case, plain X-rays, the abdomen, ultrasound. We use also fluoroscopy, CT scan, MRI, and the guided intervention procedures. So let's go down and jump direct to the abdominal X-rays. So in the abdominal X-rays we have these three main views: supine, erect, and lateral decúbitus. So supine is the patient unwell on the bed. The patient is lying on the bed. Erect, you know. And then lateral decúbitus. Lateral decúbitus is mainly to know if there is gas in the rectum. There is gas in the rectum. So when we go to report abdominal X-ray, we start to read as always from outside to inside. So we start with soft tissue, bones, and then we jump inside of the abdomen. For radiological purpose, the abdomen is divided in 4 quadrants: right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. Well, we have to look for the mark. There is the side of the patient is left or right, and also in the majority of the cases you will, the X-ray technician going to clarify if there is a supine or erect position. Also, as well, you have to know very well the anatomy if you want to do any diagnosis. Regularly, you have to know the anatomy. In your right, you can see the abdominal anatomy of the abdomen. Liver, spleen, both kidney. You see the right kidney is lower than the right, so as muscle, and the large and small in bowels. Okay, so the first thing when you start to read the X-ray from outside to inside, so the muscles, bones, then you jump into the abdomen, you have to look for these characteristics. So you have to look for any RADIOOPAQUE CALCULI. You have to look out for classifications. You have to also know something. You have to look at the gas pattern. You have to look for any foreign bodies. You have to look for intraperitoneal fluid, intraperitoneal A, organomegaly, and bony abnormalities. So today we are going to talk about all of these kind of features. So let's go to start with the classifications. So this is an example of huge calculus with lamination in the urinary bladder. You can see this is the pelvis area, and we show you this huge calculus in the urinary bladder. Another type of classification, common classification we're talking about, is this a stack horn classification. Stack horn classifications. This is when all the calyces and the pelvis of the kidney are calcified. Remember, you have to feel free to pause the video. Feel free to pause the video and then review the Google, just in YouTube, what is a stack horn classification. We have complete and incomplete, okay, for you better understanding of this kind of pathology. And you can see there is another type of classification on your left. It is a gallbladder classification. It is in the right upper quadrant, and then crossing in your left, in your right, crossing the spine. The spine, you can see tiny calcifications, very tiny calcifications. That's belong to the pancreas. So we are in the presence of chronic pancreatitis. The other one is we are in the presence of cholelithiasis. So apart of the classification, we have to look at the other. If there is any organ enlargement. So in your right, you can see the liver. How big is it? The liver, how big is it? You can find this first in the physical examination. Then you have to be sure and compare with your maybe X-rays or ultrasound. Okay, in your right now you can see this huge splenomegaly. So in your right, you can see this huge splenomegaly, okay? Or that opaque area is the spleen, which is crossing the middle line of the abdomen. So remember, when you request for a X-ray, you have to read the X-ray from outside to inside. From outside to inside. Remember that. Now let's go to enter in the pathology side, abdominal pathology side. Let's go to start about of obstruction. For obstruction, we have paralytic, ileus, and mechanical obstruction. Paralytic, ileus, and mechanical obstruction. So paralytic ileus is an obstruction of the intestine due to paralysis of the intestinal masses. Due to paralysis of intestinal masses. That's very important to know, and the causes should be any infection, maybe chemical complication of abdominal surgery, and decreased blood supply, infection inside the abdomen, kidney or lung disease. This is very important because maybe in the small babies or children will have a disease, children or small babies, sometimes they are distended. But they are distended not because they have any obstruction per se, because this essentially is second to a pneumonia or kidney infection. Pneumonia or kidney infection and nephritis. So in the adult, sometimes you can find these all patients with abdominal distension. They arrive to the OPD with abdominal distension and you think there is maybe a mechanical obstruction. Well, we are in the presence of this paralytic ileus second to pneumonia. So always you see any old patient with abdominal distension, you have to check, you have to request for chest X-ray as well. So you have to examine the chest and then request for chest X-ray as well, and rule out any pneumonia, because sometimes you are treating the patient for intestinal obstruction and for other way the patient can die because of this pneumonia, okay? Because it can become septicemia and then can keep the patient. So you have to put attention to that. Now mechanical obstruction is divided in a small bowel obstruction and large bowel obstruction. Small bowel obstruction and large bowel obstruction. The main cause of mechanical obstruction is the adhesions or scar tissue that form after surgery. Okay, that's the main cause of mechanical obstruction. Also, we have hernias, impacted stool, interstitial and tumors. And bulbous in less quantity. Okay, but before we jump into this mechanical obstruction, you have to know the colon is peripheral and contains feces and gas. The small bowels are central and contain fluid and gas. The more distal obstruction, the more loops you will see. The longer the duration of the obstruction, the bigger the fluid levels. Fluid levels can only be seen on erect or decurvature films, and small fluid levels can occur normally. It is not necessary to be obstructed to have fluid levels. It is not necessary to be obstructed to have fluid levels. That means you can get 2 or 3 fluid levels and can be normal. Okay, so let's go to jump into the small intestinal obstruction. So when you receive any patient with abdominal distension, you have to request a series of radiological studies. So you have to request first ultrasound because it's cheap and you can get the result very fast. And then you have to request the abdominal X-ray, the 3 views we're talking about at the beginning of the class. So you have to request for lateral decurvatus, you have to request for supine view, and you have to request for erect position. Now we'll explain why. So in this case, you can see in your left, that is a supine view. So supine view we mainly use to see the position of the bowels. So in this case, this is a more intestinal obstruction. So the bowels are in the middle of the abdomen, or the bowel are occupying the central part of the abdomen. okay, the central part of the abdomen, but the reason the supine in this case. And in your right, you can see the red position. So the red position is to look at it at the A-fluid levels, okay, which in the case of a small bowel obstruction like you see with the blue arrows are more wider than tall, okay, so I are wider than tall. You can see with the blue arrows, the small bowel obstruction, they are wide, the A-fluid levels are wider than tall. This is very important for you to know, okay. Let's go and check again. When you have a small patient with bowel obstruction, any of them can be paralytic or mechanical obstruction. So you have to record for the abdominal X-ray, the abdominal ultrasound, and the abdominal X-rays. Abdominal ultrasound and abdominal X-ray at the same time. So abdominal X-ray retrieves supine erect and lateral decubitus. And the ultrasound can give you the exact diagnosis in case we have a mechanical obstruction. We have paralytic ileus because the amount of gas we are going to get in the abdomen, the ultrasound is useless. Ultrasound is useless in case of paralytic ileus, but in case of mechanical obstruction it can be very, very helpful. So remember, supine view is to see the position of the bowels. In case of small bowels, they are occupying the central position of the abdomen. And in case of the erect is to see the A-fluid levels. The A-fluid levels in case of a small bowel obstruction, they are wider than tall, as the blue arrows are signalizing. So then you can see this sample of ultrasound. It's a duodenal obstruction by a carcinoma. You can see the arrow there. And then let's talk about large bowel obstruction. So the same thing, large bowel obstruction is the same thing. So the supine view is to see the position of the bowels. In this case, the large bowels are in the peripheral part of the abdomen. That is very important to know. Peripheral part of the abdomen, like in your left, and then your right is a red position. You can see this A-fluid level. They are in this case taller than wide. Okay, like in this case, you can see the arrow. They are taller than wide. Taller than wide is very important for you to know that. So that's the differentiation. Taller than wide. This is an example of the ultrasound on your left. You can see there is a carcinoma or the producing mechanical obstruction or the large bowel, and the CT scan is showing with you can see the arrows showing the mass, the tumor. Now let's go to recap this, which is very, very important. Let's go to recap this, which is very, very important. So here we have the differential between paralytic ileus and mechanical obstruction. So we have here in the first column the L in rectum or sigmoid. In case of the generalized ileus is yes. A in the small bowel. They have multiple distended small bowels, and also there is A in the large bowel, and they are also extending as well. But in case of the small bowel obstruction, there is no A in the rectum or sigmoid. So maybe they have multiple dilated loops, okay, in the small bowels, and there is no A. Very important, there is no A in the large bowel, okay. For the large bowel obstruction, there is no A in the rectum. There is no A-fluid levels or a small bowel dilatation unless the ileocecal valve is incompetent. Okay. is incompetent. That's very important to know. And the last bowel dilated. Okay, so let's go to recap this, which is very important. So we request for the 3 X-rays. Remember, the lateral decubitus is to be sure if there is gas or not in the rectum. If there is gas in the rectum, that means we are talking about paralytic ileus. Paralytic ileus or generalized ileus. Okay, paralytic ileus. If there is no gas in the rectum, so we talk about mechanical obstruction. Mechanical obstruction, which could be a small or large bowel obstruction. Okay, so lateral decubitus is for that. Then we jump to the other 2 views: supine, and erect. So supine view. The supine view is to see the location of the sternal bowel. Okay, in case of the large bowel, they are peripheral. Okay, and the diameter is up to 6 centimeters maximum, and they have the presence of obstructions. In case of small bowels, they are central, and the diameter is up to 3 centimeters maximum, and they are present of valvular connivent. Okay, that's the supine view. Then we pass to the erect position. So in erect position is to look at the airflow levels. Airflow levels in the small bowel, they are, which is on your left, they are wider than tall. In the large bowel, which is on your right, they are taller than wide. It's very important for you to know this. You have to pay attention to this very, very well, because this is a way you to be watching the whole day as a doctor. These are a very, very common pathologies. Now let's go to talk about sigmoid bolus. So this is an example of sigmoid bolus, which is I draw with a blue line. So they are the clinical features there. So you just in plain abdominal X-ray, look for a loop of large bowel extending upwards from the pelvis, described as a coffee bean appearance. You can see it's like a coffee bean appearance. Okay, that's very important for you to know. Now there is another type of bolus, not only sigmoid, because the reality is that any part of the gastrointestinal system can be twisted. From the stomach to the sigmoid. Okay, so this is an ultrasound of the patient with the bolus of the secum. Okay, which is not not too common, but yeah, you can see maybe 2 or 3 cases during your life when you pass by your rotational surgery. Okay, so this is an example. This is a simple X-ray. This is a supine and erect. You can see this is a real case from our hospital. You can see the supine and the erect are very signalized. It's on the left side. Okay, so in the erect position, you can see this unique, huge airflow level in the left abdomen. Okay, so when you see an image like that, this is pathognomonic of the cecal bolus. It's pathognomonic of the cecal bolus. This escape from this hospital or teaching hospital. So this patient, there was no pain. The patient just feeling something after a meal and 1 beer. So to feel something, there is no this huge distension, but the stomach was cramping. So you come to the hospital, we request for this ultrasound. We see this kind of image in ultrasound, so we request for the supine and erect position with the X-rays just to look at it to confirm the diagnosis. So we realize with this X-rays is okay, it's a Zika virus. So we call the surgeons, they perform the operation. You can see that huge mass in the hands of the surgeons. Okay, that huge mass in the hands of the surgeon. That's all the Zika virus. You can see all that black areas that are signs of necrosis. The signs of necrosis. Okay, this is very important to know. So you have to assess the patient very well and fast, so you can save the life of the patient. Now another pathology, very common pathology, is intussusception. Intussusception or invagination. Intussusception or invagination. Intussusception occurs when a segment of intestine prolapses into the lumen of adjacent intestine. Okay, the common cause of bowel obstruction in young children and infants between 3 months to 5 years. Is very rare under the age of 1 month. So the radiological features. So you have to look when you request for the abdominal X-ray. You have to look for soft tissue mass. Okay, soft tissue mass with this target sign. With this target sign. This target sign. But ultrasound is the gold standard and is close to 100% sensitive. Signs described included a target or bull-eye appearance on transverse scans, or sandwich appearance is described on longitudinal scanning. So we use them for the cases. Also can use a color Doppler to see vascular supply, and also we can use CT scan, but with ultrasound you can find your diagnosis. So ultrasound your gold standard for diagnosis of intussusception, and there are two basic signs. Ultrasound from the ultrasound. Okay, two signs: target sign or bull's eye sign. When you see this one in the report, so we are talking about intussusception. We're talking about intussusception. So you can see here this target sign. The target sign, and on your right you see it's like a sandwich. This is sidal view of the same pathology of the left. By intussusception look like a sandwich. Okay, very important for you. Remember target sign. So this CT scan, just to come and show you, it's not necessary really, but you see the CT scan is also like a target sign. This is pathognomonic for intussusception. Okay. Remember this one, pediatric age is between 3 months and 5 years usually. Now let's go to talk about another disease. In this case, pneumoperitoneum. Pneumoperitoneum are the other important disease in the abdomen. Remember there are a lot of perforation, also perforation for typhoid infection here in Ghana. Okay, so pneumoperitoneum is very common. So all these patients have with this pain, you have to request for X-ray, but not abdominal X-ray. You have to request for chest X-ray. So you want to diagnose pneumoperitoneum, you have to request for chest X-ray. What you want to find in pneumoperitoneum is A under both diaphragm. A under both diaphragms. First on the right side, second on the left. First on the right side, second on the left. Okay, so you can see in this picture with the head arrow, that is pneumoperitoneum. That is pneumoperitoneum. Yeah, another example, you can see both bilateral pneumoperitoneum. It's a huge pneumoperitoneum, bilateral and pneumoperitoneum. Remember to freeze the video, and then you can compare with other notes. You can Google what is pneumoperitoneum. You want to see more images about pneumoperitoneum, which is good. They could help you to understand better the pathology. Now, pneumoperitoneum is very difficult to confuse. Okay, with other pathologies. With other pathologies. So you have to make a differential with other pathologies in case of this. So it's very important because if you are sure this pneumoperitoneum and it's not, you will send the patient to a theater in vain. They want to cut the patient, that's the issue. So for pneumoperitoneum, you have to be very sure because the only solution for the patient is go to the theater. Okay, it's going to the theater. So you have to take care with this the differential diagnosis, like in this left, this atelectasis, linear atelectasis van. Okay, in both sides you can simulate the pneumoperitoneum. In the right, we have this chyliditis syndrome, which is the interposition with the colon between the liver and the right hemidiaphragm. Also can simulate a pneumoperitoneum. Another thing is a meteorism. So meteorism is this baby start to cry and swallow air in big quantities, so all the abdomen go to appear distended and then go to appear like a pneumoperitoneum. So it's very important to know that. And the other thing is subphrenic abscess. Subphrenic abscess. So you can see here, it's similar to our first picture. It's similar to our first feature. It's just X-ray and the other is the CT scan of the same patient. So you have to be very careful, okay, with this differential with the pneumoperitoneum. With the pneumoperitoneum. So okay, that is all for today. I see you in the next class.